Ladies and gents, labial incompetence or a strain in the orbicular oris muscle at rest are the two of the most well-known signs of anterior open bite. Michelle looks exactly like that. She struggles to keep her lips closed. She also has an elongated lower third of the face, which calls for a not-so-simple treatment. Well, it's a dirty job, but someone's gotta do it. Michelle's mandible growth is stronger than the norm, as you can see from the dental third class at her left. Thank God she's hyperdivergent. Thus, the mandible grows more downward than it does forward. But this is also the reason for the anterior open bite. Also, her tongue sneaks between the upper and lower incisor when swallowing, which is another reason for the open bite. The palate is contracted, causing a bilateral cross bite, which is one of the first things to take care of. And last but not least, we have some inferior crowding and an excessive space in the upper arch. And why is that so important? Because as we close upper spaces, we might retract the upper incisors. And as we solve inferior crowding, we might protract the lower ones. Not so good in a third class. No wonder the lateral radiograph looks like this. You can even see the open bite from it. The mandible's profile is elongated and it grows in a clockwise direction. So, our patient is hyperdivergent, which is consistent with the presence of an open bite. One of the easiest ways to measure the divergence is to measure the goniac angle. This one. Also, both A and B points are way too forward, leading to a skeletal biprotrusion. This means both the maxilla and the mandible have grown beyond norm. The excessive incisal proclination, lower and upper, sum up with the skeletal biprotrusion in supporting the lips, which design a full protrusive profile. So, what would you do? What is your treatment plan? I'll tell you mine in a second. Rapid palatal expander and extraction of lower first premolars and second upper ones, mostly to solve the biprotrusion. So, Michelle's parents are worried. They keep calling my office. Parents do not like premolar extractions, but they eventually agree on the treatment plan. As soon as I have the informed consent signed by both, I bond a palatal expander with molar tubes, which I keep in place even after the activations to prevent any undesirable early relapse of the expansion. We now bond the brackets, except for the extraction teeth, and start alignment with the 013 Q-Night wire. After a few months, it's time for the extractions. At this point, the surgery goes well. We're all happy. The surgeon took 44 and 34 off, but Michelle looks a bit tired. I think that's normal after 2 extractions, but it's actually not. A serious surgical complication occurs. It is so serious that I think it's better not to risk again with the upper ones. So, even though you wouldn't change horse in the middle of a river, I had to change treatment plan in the middle of the treatment. Now, we need to close the lower extraction spaces, and we do that on a 020 SS Australian wire with the help of a power chain. As the molars and premolars come a bit forward, canines and incisors come backward, roughly twice as much, because they have less radicular surface and offer less resistance to movement. The idea beyond the use of extractions in situations where we have a tendency for open bite is exactly this. As the incisors move backward, they lose torque and move up a bit in a way that tends to close the bite. After almost 2 years of treatment, the situation is good enough for debonding. As you can imagine, the advancement of lower molars has caused a full third-class occlusion, which is absolutely acceptable as we have 2 missing teeth in the lower arch. There is no functional impairment or any kind of risk related with that kind of occlusion, so do not worry if it happens to you. We have obtained an acceptable overbite thanks to the lower extractions, and now we need to make sure lower teeth remain aligned. Thus, I splint from premolar to premolar. Michelle is also given a thermoformed retainer for the upper arch to wear at night. Well, no doubt skeletal biprotrusion has stood still. I have to admit, I kind of like her profile. For me, a biprotrusion is always better than a biretrusion. But remember, the patient is usually poorly aware of his or her profile. The thing she notices is the smile. The smile and the smile. She doesn't care about the occlusion. She cares about the smile. The overbite is just there on the verge of oblivion. Treating the third class at 13 is a bit risky because at this age, the maxilla has almost ended its growth, while the mandible continues to grow until 18 or 19 years old. If you're unlucky, you might finish at 14 with a good occlusion and meet the patient 4 years later with perfectly aligned teeth and an anterior crossbite. And with a furious mother too. So, make sure to point out this risk when treating these patients. Michelle's panoramic shows her lower wisdom teeth erupting in occlusion with the upper second molars, a thing that happens quite often in cases like this one. All the better for our patient. And at last, the pre-treatment lateral radiography compared with the post-treatment one. The only change that's visible without the use of a telescope is the retraction movement of the lower incisor, the guest of honor of the event, the one that has closed the bite almost alone. Great job, lower incisor!